Question 1. A 67-year-old established patient is seen for an annual wellness exam, AWE, and during the same visit, the provider addresses and manages her long-standing, stable type 2 diabetes mellitus with diabetic polyneuropathy. How should the evaluation and management E/M services be reported? I. G0439 for the AWE only. B. 99213 for the E/M and G0439-25 for the AWE. C. G0439 for the AWE and 99,213-25 for the E/M. D. 99,213-25 for the E/M service only, as diabetes management is not part of an AWE. Answer C. G0439 for the AWE and 99,213-25 for the E/M. This question tests the coding concept of preventive care and significant, separately identifiable E/M services performed on the same day. The keyword annual wellness exam points to the HCPCS code G0439 for Medicare patients, which must be listed first, and the keyword addresses and manages indicates a distinct, billable E/M service, 99213. For a separate, problem-focused service to be billed with a preventive service, a -25 modifier must be appended to the E/M code, 99213, to show it was a significant, separate service. The G0439 does not get a modifier because it is the primary, preventive service, and the E/M code is selected based on the medical decision-making or time involved in managing the stable diabetes. Here is an easy way to remember it. Always put the preventive code first and attach modifier -25 to the problem-oriented E/M code if it's separate and documented. Question 2. A patient is diagnosed with esophageal varices due to alcoholic cirrhosis of the liver. What is the correct sequencing of the ICD-10-CM codes? I. I8511 K7030. B. K7030 I8511. C. K7030 I8511 F1020. D. I8511 K7030 F1020. Answer B. K7030 I8511. This question is about ICD-10-CM sequencing guidelines when an underlying condition causes a manifestation. The key phrase, esophageal varices due to alcoholic cirrhosis, indicates a causal link, where the cirrhosis is the underlying etiology, cause, and the varices are a manifestation. ICD-10-CM coding guideline IB7 instructs that in cases of due to or with links, the underlying condition, cirrhosis, K7030, must be coded first, followed by the manifestation, varices, I8511. The use of the term alcoholic also suggests a potential code for alcohol dependence, F1020, but without documentation of dependence or abuse. Only the directly linked conditions are required. When a condition is clearly due to another condition, code the cause first, then the effect. Question 3. A surgeon performs a total abdominal hysterectomy with bilateral salpingo-oophorectomy and omentectomy for a patient with ovarian malignancy. Which CPT code combination correctly represents the surgical procedure? I. 58150, 58700, 49255. B. 58,956. C. 58150, 58,940. D. 58,275. Answer B. 58,956. This question tests the surgical coding principle of using the most comprehensive code, avoiding unbundling, which is a key concept in CPT surgery. The procedure involves a total abdominal hysterectomy, bilateral salpingo-oophorectomy, and omentectomy, all for ovarian malignancy, which are all component parts of a more extensive procedure for gynecological cancer. CPT code 58956, resection, initial, of ovarian, tubal or primary peritoneal malignancy with bilateral salpingo-oophorectomy and omentectomy, is a single, bundled code that includes the hysterectomy, salpingo-oophorectomy, and omentectomy when performed for malignancy, making it the most accurate choice. Always look for the single, most comprehensive code in CPT to avoid fragmenting the service into multiple codes. Question 4. An independent laboratory receives a request for a routine urinalysis without microscopy and a CBC complete blood count with automated differential. Which is the correct CPT code combination? I. 85025 81001. B. 80061. C. 81003 85025. D. 80053. Answer C. 81003 85025. This question tests knowledge of CPT pathology and laboratory codes, specifically distinguishing individual tests from bundled panels. The keywords routine urinalysis without microscopy should lead to CPT code 81003 and CBC complete blood count, with automated differential points to code 85025. It is important to note that a lab panel, like 80053 or 80061, cannot be used unless all components of that panel are ordered and performed. Since these are two distinct, non-panel tests, they must be coded separately. Always check the official CPT panel definitions. If not all components are performed, you must code the individual tests. Question 5. A 45-year-old patient presents for a follow-up visit 1 month after a previous total knee replacement. The provider is managing the patient's postoperative pain with adjustments to medication and checking the surgical incision site. The patient's condition is stable. What is the correct E/M code for this service? I. 99,213-24. B. 99,214. C. The visit is not separately billable. D. 99,024. Answer C. The visit is not separately billable. This item assesses understanding of global surgical packages, a critical billing concept. The keyword follow-up visit and the timing 1 month after a previous total knee replacement are the clues, as a total knee replacement, major surgery, typically has a 90-day global period. Postoperative management, like checking the incision site and adjusting pain medication for the surgery, is included in the initial surgical fee. The code 99024 is simply an internal tracking code used to document the visit but carries no separate charge. Remember that routine, uncomplicated follow-up care for 90 days after major surgery is part of the global package and cannot be billed. Question 6. A patient is treated for a complex repair of a 60 cm laceration to the forearm and a simple repair of a 30 cm laceration to the cheek. What CPT code F should be reported? I. 13121 12011-59. B. 13,121. C. 13121 12032. D. 12014 12032. Answer B. 13,121. This question tests the CPT rule for coding multiple laceration repairs on different anatomic sites and complexity levels. The keywords are complex repair of a 60 cm laceration to the forearm and simple repair of a 30 cm laceration to the cheek. The CPT guidelines for wound repair state that when multiple wounds are repaired, the most complex repair is listed first, and the lengths of repairs of the same complexity level within the same anatomic grouping are summed. Simple and complex repairs are never added together, nor is a simple repair on the face, 12011-12018, bundled into a complex repair on the trunk/extremities, 13121-13122. However, CPT guidelines prohibit separate coding of simple repairs when complex or intermediate repairs are performed in the same anatomical area, and payers typically only reimburse the highest level of repair. Therefore, only the complex repair, 13121 for 60 cm of the forearm, is reported, as the simple repair is considered bundled. To be safe in practice, always report only the most complex repair unless an intermediate repair and a simple repair are performed in different anatomical areas. Question 7. The combining form nephr/o means I. Nerve. B. Kidney. C. Liver. D. Lung. Answer B. Kidney. This is a basic medical terminology question, focusing on common combining forms used throughout medical documentation. The combining form nephr/o is the root word for the kidney, which can be seen in terms like nephritis, inflammation of the kidney, or nephrectomy, surgical removal of a kidney. Understanding these basic roots is crucial because it allows the coder to quickly translate documentation and correctly locate the pathology in the ICD-10-CM index. Here's a simple memory trick. Nephrologists treat nephrons, which are the main functioning units of the kidney. Question 8. A 52-year-old male is admitted with acute exacerbation of COPD. The patient is a current tobacco smoker. What is the correct ICD-10-CM code assignment? I. J44 1 F17 210. B. J44 1 Z72 0. C. J44 9 F17 210. D. J44 0 Z72 0. Answer I. J44 1 F17 210. This question tests the ICD-10-CM concept of coding a diagnosis, including an acute exacerbation, along with an associated substance use status. The keyword acute exacerbation of COPD is a combination code, represented by J44-1, which is the primary diagnosis. The patient is a current tobacco smoker, which, according to ICD-10-CM guidelines, should be coded with the appropriate tobacco dependence code, F17-210, nicotine dependence, cigarettes, uncomplicatedly, because current use often implies dependence. Remember, current use codes, Z72-0, are typically only used when the use is not documented as dependence or abuse, or if a more specific dependence code is available. Question 9. A patient is brought to the operating room, or for a 3-hour procedure on a fractured elbow, requiring general anesthesia. The patient has a severe, controlled systemic disease, type 2 diabetes with chronic, managed hypertension. Which physical status modifier should be appended to the anesthesia CPT code? I. P1. B. P2. C. P3. D. P4. Answer C. P3. This question tests the use of anesthesia physical status modifiers, a key concept for calculating anesthesia reimbursement. The clue is severe, controlled systemic disease, specifically type 2 diabetes with chronic, managed hypertension, which aligns with the definition of physical status modifier P3. P2 is for a patient with mild systemic disease, and P4 is for a patient with severe systemic disease that is a constant threat to life. When the medical record indicates a severe systemic illness that is managed but still present, the P3 modifier is the correct choice. Always remember the hierarchy. P1 is healthy, P2 is mild, P3 is severe but controlled, and P4 is severe and a constant threat to life. Question 10. Which of the following best describes the resource-based relative value scale, RBRVS? I. A system for classifying diseases and injuries. B. The fee schedule used by Medicare to reimburse providers for services. C. A system for classifying inpatient hospital procedures. D. The federal law protecting patient health information. Answer B. The fee schedule used by Medicare to reimburse providers for services. This question covers a fundamental concept in healthcare billing and compliance, the Resource-Based Relative Value Scale, RBRVS. The RBRVS is the methodology Medicare uses to determine how much to pay physicians, factoring in the work required, the practice expense, and the professional liability insurance. It is the primary reimbursement model for physician services under Medicare Part B. It is important not to confuse RBRVS with other systems, as ICD-10-CM classifies diseases, and HIPAA is the federal law for patient health information. Here's a good tip. The R in RBRVS stands for resource, which is what the payment is based on. Question 11. A physician dictates that an X-ray of the lower leg was performed. The report specifies a 2-view projection for injury. Which CPT code is correct? I. 73,590. B. 73,592. C. 73,600. D. 73,590 to 52. Answer: I. 73,590. This question tests knowledge of diagnostic radiology coding, specifically for extremities and the number of views. The key information is X-ray of the lower leg and 2-view projection, which requires looking up the correct anatomic section. CPT code 73590 represents radiologic examination, tibia and fibula, 2 views, which accurately reflects the procedure. Code 73592 is for 3 or more views, and 73600 is for the ankle, making them incorrect choices. Always be precise and check the exact number of views and the specific bone or joint examined when coding diagnostic X-rays. Question 12. A 30-year-old patient is seen for an initial office visit for a persistent cough. The physician performs a problem-focused history and exam, and the medical decision-making, MDM, is of low complexity. Total time spent is 25 minutes. How should this E/M service be coded? I. 99,202. B. 99,203. C. 99,213. D. 99,214. Answer: B. 99,203. This E/M question tests the understanding of coding for new patients and the 2 methods for code selection, 3 key components or total time. The keyword initial office visit means this is a new patient. E/M codes 99,202 to 99,205. For a new patient in the outpatient setting, the code is chosen based on the level of medical decision-making, MDM, or the total time spent. With a low complexity MDM, the correct code is 99,203. While the time, 25 minutes, is less than the required time for 99,203, 30-44 minutes, the MDM criteria are met at the 99,203 level. Remember, for a new patient E/M, you only need to meet the documentation requirements for 2 of the 3 key components, or the total time, if used, must meet or exceed the minimum. Question 13. A patient is admitted for a total mastectomy due to malignant neoplasm of the left breast. The pathology report shows the margins are clear and the estrogen receptor status is positive. What is the correct ICD-10 CM code assignment? I. C50 912. Z17 0. B. C50 912. Z79 899. C. Z17 0. C50 912. D. C50 912. Answer: D. C50 912. This question assesses proper coding for a malignant neoplasm diagnosis in ICD-10 CM and the use of status codes. The key diagnosis is the malignant neoplasm of the left breast, which is C50 912. The estrogen receptor status positive, Z17 0, is important clinical information, but, according to ICD-10 CM guideline IAB-10, is typically not coded on a hospital inpatient or outpatient claim unless it directly impacts the treatment or is specifically designated for reporting by a payer. Since the mastectomy is for the malignant neoplasm itself, only the primary malignancy code is required in this scenario. Focus on coding the principal diagnosis. Only code secondary findings like receptor status when a specific guideline or payer instruction directs you to do so. Question 14. A patient has a bone spur, osteophyte, removed from their right knee during an open procedure. The surgeon files the joint surface to ensure smooth movement. Which CPT code is most appropriate? I. 27,403. B. 27,414. C. 29,875. D. 27,360. Answer: D. 27,360. This question tests musculoskeletal surgery coding, requiring differentiation between a simple excision and a joint procedure. The procedure is an open removal of an osteophyte, bone spur, from the knee, which is a tumor-like bony growth. CPT code 27360, excision of tumor or tumor-like condition of femur, lower end, or knee area, soft tissue or bone, is the most specific and correct code for the open removal of a bone spur in the knee area. Code 29875 is for an arthroscopy, which is a different approach, and 27403/27414 relate to more complex meniscus or osteochondral procedures. When coding for an excision of a bone spur, confirm the approach, open/arthroscopy, and the specific anatomical area to choose the most precise code. Question 15. The physician documents that a patient has a stage 4 decubitus ulcer, pressure ulcer, on their right hip. What is the correct ICD-10 CM code assignment? I. L89-214. B. L89-224. C. L89-294. D. L89-219. Answer: I. L89-214. This question tests the use of ICD-10 CM combination codes for pressure ulcers, which require specificity for anatomical site, laterality, and stage. The key is stage 4 decubitus ulcer on the right hip. The correct code must be built. L89 for pressure ulcer, the 4th character for the site, 2 for hip, the 5th character for laterality, 1 for right, and the 6th character for the stage, 4 for stage 4. This combines to L89-214. Pressure ulcer coding demands complete specificity. Always ensure you have the site, the laterality, left/right/unspecified E, and the stage documented to select the correct final code. Question 16. A patient is seen for removal of a cerumen impaction, earwax buildup, in both ears. The procedure required the use of an operating microscope and mechanical removal with a curette by the physician. What is the correct CPT code? S. I. 69210. B. 69210-50. C. 69210, 69210-50. D. 69210-50, 92504. Answer: I. 69210. This question tests the correct application of a CPT code that explicitly includes bilateral services. The key service is removal of a cerumen impaction in both ears using a curette, a mechanical tool, which is represented by CPT code 69210, removal impacted cerumen requiring instrumentation, unilateral or bilateral. Because the code description itself includes the term unilateral or bilateral, it means the single code covers both ears, and a modifier -50 bilateral procedure is not appended. Always read the code description carefully, as some codes, like 69210, are inherently bilateral and do not require a modifier. Question 17. The primary reason an advance beneficiary notice, ABN, is given to a patient is I. To inform the patient of their right to appeal a claim denial. B. To document that the service is considered medically necessary by the physician. C. To inform the patient that Medicare may not pay for a service and the patient agrees to pay if denied. D. To confirm the patient's insurance coverage and copayment amount prior to the service. Answer: C. To inform the patient that Medicare may not pay for a service and the patient agrees to pay if denied. This is a core billing and compliance concept related to Medicare coverage rules. An advance beneficiary notice, ABN, or Form CMS R131, is a written notice given to the patient when the provider believes Medicare may not cover the service because it is not considered medically reasonable and necessary. The keyword is primary reason, and the goal of the ABN is to transfer financial responsibility to the patient before the service is rendered, allowing the patient to choose whether to receive it or not. Remember that the ABN is required before services are provided and is only for services where Medicare coverage is uncertain or questionable. Question 18. A pathologist examines a surgical specimen and provides an opinion on the tissue sections, but a separate physician interprets the patient's medical data to determine the need for and timing of the surgical procedure. Which CPT code describes the pathologist's service? I. 88,305. B. 88,321. C. 88,307. D. 88,329. Answer: I. 88,305. This question tests the difference between general surgical pathology services and specific consultation services in the CPT pathology and laboratory section. The key service is the pathologist examines a surgical specimen and provides an opinion on the tissue sections, which falls under the surgical pathology 88300-88309 codes. The majority of complex surgical specimens, like a major organ or a large biopsy, are reported with CPT code 88305. Consultation codes 88321-88325 are for when the pathologist is asked for an additional opinion on slides or reports already prepared by another pathologist. For routine, non-consultative tissue examination, choose the appropriate code from the 88300 series. Question 19. A radiologist performs a CT scan of the abdomen. The documentation states that oral contrast was administered to the patient. What is the correct CPT code? I. 74,160. B. 74,170. C. 74,150. D. 74,176. Answer: C. 74,150. This question tests a key guideline in CPT radiology regarding the definition of a study with contrast. The key clue is oral contrast was administered. CPT guidelines specify that oral and rectal contrast administration does not qualify as a study with contrast because it is not administered intravenously, intraarterially, or intrathecally. Therefore, the service must be coded as a CT of the abdomen without contrast, which is CPT code 74150. If the provider had given for contrast, the code 74160 would be used. Always remember this specific radiology guideline: oral or rectal contrast does not count as contrast for coding. Question 20. Which element is not required when determining the level of a new patient office E/M service 99202-99205, based on the traditional key component method? I. Extent of history. B. Extent of physical examination. C. Complexity of medical decision-making, MDM. D. Counseling and/or coordination of care. Answer: D. Counseling and/or coordination of care. This E/M question tests the understanding of the traditional three key components used to select the level of a new patient E/M service. The key elements for new patient E/M are history, examination, and medical decision-making, MDM, and the level chosen must meet the requirements for at least two out of the three components. Counseling and/or coordination of care is only considered a time-based component that can be used to select the E/M level when it dominates more than 50% of the encounter time, but it is not one of the three traditional key components. Remember, the three key components for E/M are history, exam, and MDM. Anything else is an ancillary factor for time-based coding. Question 21. A patient with HIV presents with an ulcerated lesion on the tongue. The provider diagnoses the patient with oral hairy leukoplakia, OHL. What is the correct ICD-10 CM coding sequence? I. K13, 3, B20. B. B20, K13, 3. C. B20, R21. D. K13, 3. Answer: B. B20, K13, 3. This question addresses the ICD-10 CM rule for sequencing the human immunodeficiency virus, HIV, when a patient has a condition related to HIV, which is the concept being tested. The keyword is HIV presents with and a manifestation of OHL. According to ICD-10 CM guidelines, B20 human immunodeficiency virus HIV disease is the principal diagnosis code when the patient's condition, OHL, K13-3, is a complication or manifestation of the HIV infection. The OHL code, K13-3, is then reported as a secondary diagnosis. Always place B20 as the primary diagnosis, regardless of the reason for the encounter, if the patient is treated for an HIV-related condition. Question 22. Which HCPCS Level II code would be used to report the supply of a custom-fabricated ankle-foot orthosis, AFO? I. L4360. B. L1970. C. L1900. D. L5000. Answer B. L1970. This question tests knowledge of HCPCS Level II coding, specifically for durable medical equipment, prosthetics, orthotics, and supplies, MIPOs. The key service is for a custom-fabricated ankle-foot orthosis, AFO. HCPCS Level II code L1970, ankle-foot orthosis, plastic, rigid anterior tibial section, floor reaction, custom-fabricated, is an example of a code for a custom-fabricated AFO. The other options are for prefabricated AFOs, L4360, a basic AFO, L1900, or a lower extremity prosthesis, L5000. Always confirm the specific type, off-the-shelf, custom-fitted, or custom-fabricated when selecting orthotic and prosthetic codes. Question 23. An elderly patient suffers a comminuted fracture of the shaft of the femur. The surgeon performs an open reduction with internal fixation, ORIF. Which CPT code category does this procedure fall under? I. 24,000 to 24,999. B. 27,506. C. 25,000 to 25,999. D. 29,881. Answer B. 27,506. This question tests basic CPT organization and the specific code for a common musculoskeletal procedure. The keywords are comminuted fracture of the shaft of the femur and open reduction with internal fixation, ORIF. CPT code 27506. Open treatment of femoral shaft fracture, with or without bone grafting, with or without internal or external fixation, is the correct procedure code. The 24,000 series is for the humerus/elbow, and 25,000 is for the forearm/wrist. Understanding the CPT section organization is crucial, as the 20,000 series musculoskeletal system is grouped by anatomical site. Always use the CPT index to find the correct anatomical section first when coding orthopedic procedures. Question 24. Which anatomical structure is responsible for filtering blood and forming urine? I. Ureter. B. Nephron. C. Urinary bladder. D. Urethra. Answer B. Nephron. This is an anatomy question focusing on the functional unit of the urinary system. The keyword clues are filtering blood and forming urine. The nephron is the microscopic, fundamental structural and functional unit of the kidney, responsible for regulating water and soluble substances by filtering the blood, reabsorbing what is needed, and excreting the rest as urine. The ureter and urethra are ducts, and the bladder is for storage. Think of the nephron as the tiny, highly specialized workhorse that actually creates the urine. Question 25. A new patient is seen in the office for an acute exacerbation of asthma. The physician spends 40 minutes performing and documenting the medically appropriate E/M service, and all the time was dedicated to the patient's care. What is the correct E/M code selection? I. 99,202. B. 99,203. C. 99,204. D. 99,205. Answer C. 99,204. This question tests the use of total time as the E/M code selection factor for new patients. The keywords are new patient and spends 40 minutes performing, dedicated to the patient's care. For new patient office visits, 99202-99205, the code can be selected based on the total time spent on the date of the encounter. CPT code 99204 is defined by a total time of 40 to 54 minutes on the date of the encounter, making it the correct selection for 40 minutes of documented service. Always ensure the documented time meets the minimum time requirement for the level you select when using time as the primary factor. Question 26. A physician performs an anterior cervical discectomy with arthrodesis fusion at 2 interspaces, C5, C6, and C6, C7, using a separate bone graft obtained from the patient's hip. What is the correct CPT code S for the procedure? I. 22551, 22552, 20,937. B. 22554, 22,585. C. 22551, 22552, 20,938. D. 22554, 22585, 20,938. Answer D. 22554, 22585, 20,938. This question assesses complex CPT musculoskeletal coding for spinal fusion procedures, specifically understanding the primary and add-on codes for multiple levels and graft harvesting. The keywords are anterior cervical discectomy with arthrodesis at 2 interspaces and a separate bone graft, autograft. The primary code is 22,554, arthrodesis, anterior interbody, including disc space preparation, discectomy, osteophytectomy, and graft placement, cervical below C2, which covers the first interspace. The add-on code 22585 is used for each additional interspace. The code 20938, bone graft, autogenous, obtained through separate incision, is used for the separately harvested autograft. Spinal fusion is always coded with a primary code for the first level and an add-on code for each subsequent level, plus an appropriate code for the graft if applicable. Question 27. When an insurance company sends a remittance advice RAY indicating a claim has been partially paid and the patient owes a deductible, which document should the medical billing specialist review first? I. The patient's medical record. B. The CMS 1500 claim form. C. The explanation of benefits, EOB. D. The payer's fee schedule. Answer C. The explanation of benefits, EOB. This is a billing and revenue cycle concept question regarding the next step after a payer response. The keywords claim has been partially paid and remittance advice, RAY, are the clues, as the RA accompanies the explanation of benefits, EOB. The EOB/RA is the specific document sent by the insurance company that details the actions taken on a claim, including the amount paid, the reasons for payment/denial, and the patient responsibility, like a deductible. Reviewing the EOB is the essential first step to understand the payment details and decide on the next action for patient billing. Always use the EOB/RA to find the exact reason for payment or non-payment before taking any further action. Question 28. A surgeon performs a total laparoscopic cholecystectomy with an intraoperative cholangiogram. What is the correct CPT code selection? I. 47562, 47,563. B. 47563, 47,562. C. 47,600. D. 47,564. Answer I. 47562, 47,563. This surgical coding question focuses on the appropriate combination and sequencing of an inclusive procedure and a separately billable component. The core procedure is a total laparoscopic cholecystectomy, which is CPT code 47562. The intraoperative cholangiogram is a separate diagnostic procedure performed during the surgery. CPT code 47563, laparoscopy, surgical, cholecystectomy with cholangiography, is the add-on code that can be used in addition to 47,562 as directed by the CPT manual, and it must follow the primary procedure code. Code 47564 is for the more extensive common duct exploration. Use the primary surgical code first, 47562, and then append the appropriate add-on code, 47563, for the additional service performed. Question 29. A coder reviews a chart noting a diagnosis of recurrent malignant melanoma of the back. Which ICD-10 cm coding guideline applies? I. Code first the primary malignancy, then the recurrence. B. Code the recurrence as the primary diagnosis. C. Code the primary site, but only if there is an excludes one note. D. Code C4351 with the appropriate 7th character. Answer D. Code C4351 with the appropriate 7th character. This is a key ICD-10 cm guideline for coding recurrences of a malignant neoplasm. The concept being tested is the definition of a recurrent malignancy. The ICD-10 cm guideline states that when a primary malignancy has been excised or eradicated and the patient is receiving treatment for a recurrence of that same malignancy, the code for the primary malignancy, C4351 for the back, is used with a 7th character, A, D, or S, to indicate the episode of care, e.g., initial encounter for treatment. This differs from a personal history of malignancy, C85, where the original tumor is no longer being treated. When coding for a recurrence, always use the code for the primary malignancy site, indicating the current episode of care with a 7th character. Question 30. A nurse administers an injection of a therapeutic drug to a patient. The physician documents the drug dosage as 10 milligrams. The HCPCS Level II code for the drug is JXXXX, described as injection, drug name, 5 milligrams. How many units of JXXXX should be reported on the claim? I. 1 unit. B. 2 units. C. 5 units. D. 10 units. Answer B. 2 units. This is a practical HCPCS Level II and billing question about calculating units for drugs. The concept tested is the relationship between the dosage given and the unit of measure in the code description. The patient was given a 10 milligrams dosage, and the HCPCS code JXXXX is defined in units of 5 milligrams. To determine the correct number of units, the total dosage, 10 mg, is divided by the code's unit dosage, 5 mg, resulting in 2 units. Always divide the documented total dose by the dosage listed in the HCPCS code to determine the billed units. Question 31. A patient with a chronic cough is referred for a fiber optic bronchoscopy. During the procedure, the physician visually examines the trachea and bronchi and performs an endobronchial ultrasound, EBUS, to guide a transbronchial needle aspiration, TBNA, of a peribronchial lymph node. Which CPT code, S, is / are reported? I. 31622. B. 31629. 31620. C. 31652. D. 31628. 31629. Answer C. 31652. This complex endoscopy question tests the knowledge of new bundled CPT codes for advanced bronchoscopy techniques. The keywords are fiber optic bronchoscopy, endobronchial ultrasound, EBUS, and transbronchial needle aspiration, TBNA. CPT code 31652, bronchoscopy, rigid or flexible, including all fluoroscopic guidance, with endobronchial ultrasound, EBUS, guided transbronchial needle aspiration, TBNA, in mediastinal and/or hilar lymph nodes, S or MAS ES, is the single comprehensive code for the EBUS-guided TBNA. Because this new code includes the TBNA and EBUS, the component codes 31628, 31629 are not reported separately. Always check the CPT introductory notes to confirm if a specific advanced procedure code bundles other components, like EBUS and TBNA. Question 32. Which component of the skull forms the posterior and inferior part of the cranium? I. Parietal bone. B. Temporal bone. C. Occipital bone. D. Sphenoid bone. Answer C. Occipital bone. This is a straightforward anatomy question focused on the bones of the skull. The keywords posterior and inferior point to the back and base of the head. The occipital bone is the main bone of the back and lower part of the skull. A solid understanding of directional terms like posterior, back, and inferior, below, is vital for quickly locating structures when coding trauma or surgical procedures. Here's a quick tip. Think of the O in occipital as being at the outer back of the head. Question 33. A patient is seen by a specialist for an in-office consultation at the request of the patient's primary care physician. The primary care physician's request and the specialist's written report back to the PCP are documented. Which CPTE/M code category is appropriate for the service? I. 99,202 to 99,205 new patient office visit. B. 99,212 to 99,215 established patient office visit. C. 99,241 to 99,255 consultation codes. D. The service must be coded with modifier -32. Answer: I. 99,202 to 99,205 new patient office visit. This question tests a crucial change in E/M coding guidelines, specifically the elimination of the CPT consultation codes by Medicare and many other major payers. The keywords are in-office consultation at the request of the patient's primary care physician. Although the service technically meets the definition of a consultation, for payment purposes by most payers, CPT codes 99,241 to 99,255 are no longer accepted. Instead, the service is reported using the appropriate new patient 99202-99205 or established patient 99212-99215 office E/M codes, depending on the patient's status with the specialist. Assume the patient is new to the specialist and use the new patient codes unless otherwise instructed. The key takeaway is, do not use CPT consultation codes unless you confirm the payer specifically accepts them. Question 34. A provider performs a fine needle aspiration, FNA biopsy without imaging guidance on a superficial mass in the patient's neck. The surgeon interprets the specimen. Which CPT code is reported for the FNA procedure? I. 10,021. B. 10,005. C. 10,004. D. 60,100. Answer: I. 10,021. This question addresses the coding of fine needle aspiration, FNA biopsies, focusing on the correct code set based on the type of guidance used. The key phrase FNA biopsy without imaging guidance points to the older FNA codes. CPT 10021, fine needle aspiration biopsy without imaging guidance, first lesion. The newer 10,004 to 10,012 code series is reserved for FNA procedures performed with imaging guidance, e.g., ultrasound, fluoroscopy. Note that 10021 is still valid for non-image guided superficial FNAs. Always determine if imaging guidance was used. If no imaging guidance is documented, you must use CPT code 10021. Question 35. A patient is receiving chemotherapy for a primary malignant neoplasm of the lung. Which C code is used to report the patient's personal history of colon polyps? I. Z8522. B. Z86-010. C. Z87-31. D. Z87-89. Answer: C. Z87-31. This question tests the proper use of ICD-10 CMZ codes for personal history. The keywords are personal history and colon polyps. Polyps are generally classified as a disease of the digestive system, which are non-neoplastic conditions. Z87-31, personal history of Correctides colon polyps, is the correct code to report a prior condition that is no longer present but is relevant to the current care. Neoplasm codes, Z85, are for a personal history of malignancy, and Z86-010 is for a personal history of malignant neoplasm of the digestive organs. History codes, Z80-Z87, are essential secondary codes. Always make sure the code chosen correctly reflects whether the history is for a benign condition, Z87, or a resolved malignancy, Z85.